Good afternoon and welcome everyone to our webinar for today. I'm Gabrielle Darville-Sanders, Strategic Director for the National HPV Vaccination Roundtable, and I'll serve as today's moderator. Welcome to our session titled Preventing Cancer Through HPV Vaccination, EHR Age 9 Case Studies. So today, in observation of the 2025 International HPV Awareness Day, we look forward to highlighting how EHR system utilization and strong provider recommendations can promote HPV vaccination series completion and elevate healthcare outcomes. We are very excited about our lineup of speakers. Before we begin, we would like to address a few housekeeping items. Today's webinar will be recorded. The link to view the recording and a PDF of today's slides will be shared with all who have registered. In addition, the recording link will be posted publicly in the future. If you should have any issues today during our webinar or have any questions for our presenters, please use the chat. To ensure that there are no disruptions during the presentation, all participants have been muted by the host. And to ensure that we have sufficient time for Q&A at the very end, we will be sharing our panelists' bios in the chat. So our first presenter today is going to be Dr. Michelle, Shelley as we like to call her, Fiscus. Shelley Fiscus serves as the Chief Medical Officer at the Association of Immunization Managers. She is also currently serving as one of our two chairs for the ACS National HPV Vaccination Roundtable. She will be presenting on the topic of protecting against HPV, where are we? Let's go ahead and welcome Dr. Fiscus.
All right, thanks, Gabby. It's good to be with all of you, and you can go ahead to the next slide. I'm just going to do a little level set over sort of where we are with HPV in the United States at this moment. So when we look at the burden of cervical cancer, and cervical cancer is the easiest HPV-related cancer to track because it's almost always caused by HPV, whereas head and neck can be caused by tobacco and other issues. But this is the map of the burden of cervical cancer across the United States, and with the red being the higher incident rates of cervical cancer. So presumably those are HPV infections in those states. Next slide, please. If you look at the vaccination rates, you can see that the same states that have some of the highest cervical cancer burden rates have some of the lowest immunization rates, especially some of the southern states. But only a handful of states, six states in DC, are either getting close to or have surpassed the Healthy People 2030 goal of having 80% of adolescents vaccinated against HPV. So we still have a long way to go, and there are too few of those Black states on this map. Next, please. These are this is data that was put out by the Kaiser Family Foundation, and this is based on the NIS teen immunization surveys, and it looks at HPV vaccination initiation for 13 to 17-year-olds, so technically late to getting vaccinated by their type of insurance. And you can see overall, prior to the pandemic, all of these curves were trending upward. And then really now for the first time in a very long time, we have seen some downtrending curves. The one that I want to point out is that 58% of adolescents who are uninsured have been vaccinated with HPV vaccine. And that's a little bit puzzling, maybe, because if you're uninsured and you're under the age of 19 in the United States, you qualify for the Vaccines for Children program. And so the HPV vaccine should be available to you at no cost. Cost should not be a barrier to getting children under the age of 19 vaccinated. But it's possible that because of this population being insured, that they don't have ready access to healthcare and to the healthcare providers that need to be recommending that they receive that vaccine. And so you see a rather marked disparity amongst individuals who are uninsured. The rest are sort of clustered there. The other bar or the other graph which is the blue one, includes CHIP, the Children's Health Insurance Program, and military insurance and Indian Health Service. And as opposed to the Medicaid and the private insurance graphs. And you can see the overall, the purple one is about 76.9%. So overall, we're getting towards those HP healthy people 2030 goals, but there's a lot of disparity here. Next, please. And for years, as clinicians, we have been bundling our language around the adolescent vaccination visit to be your child is due for Tdap, HPV, and meningococcal vaccines. And you can see that historically we have had pretty even uptake of Tdap and meningococcal vaccine, even though meningococcal vaccine often is not required for school entry. But that yellow curve down below is the HPV vaccination up-to-date curve. And the difference, even though we're supposed to be imaging these together, the difference between those two curves is pretty striking, that we are not getting people vaccinated during that adolescent visit when we're recommending Tdap and meningococcal vaccines. Next, please. So why is that we're not seeing this? So in some recent studies that have been done that I've documented here, parents a lot of times feel that the vaccine is not necessary, that they have safety concerns, and notably safety concerns have increased by about 15% annually over the last decade and a half or so, which is concerning. That they're not getting strong recommendations from their healthcare providers, and we know that is the real driver to get people immunized, is for them to hear a strong recommendation from their healthcare provider. Lack of knowledge about what HPV is and why we need to prevent it, that it's tied to cancer, and thinking that because their child is not sexually active that they don't need to get an HPV vaccine. Next, please. And then on the provider side, we hear that there are sometimes lack of specific workflows around how you recommend HPV vaccine in the medical setting. They might not be using the vaccine information sheets that are given out with each vaccine that talk about the importance of getting vaccinated and what some of the risks and benefits are to that. That there may be inconsistent messaging across the medical community. So some physicians or other healthcare providers might be making strong recommendations while others are not, and still others might be actively recommending against it. Individual healthcare practitioners may have personal hesitancy about HPV vaccine because of religious reasons or others. And then just plain burnout, in that we've been talking about vaccines for a really long time, and COVID especially has really taken a toll, and I think made some physicians and other healthcare workers a little bit shy to bring up vaccines that might seem to be controversial, just because of the desire to avoid any kind of confrontation with patients. It's just it's difficult to continue to do that. Next, please. So there are several things that we can do together to work on improving HPV immunization rates. From the clinical side, talking points, giving good talking points to clinicians so that they know how to make a good recommendation, helping them to institute standing orders so that nurses and NMAs who are looking at the medical chart and see that someone is in need of an HPV vaccine can go ahead and administer that vaccine right at that time. Reminder recall using EHR to identify patients who might be missing vaccines, and to send them text messages or postcards to remind them to come into the office to get those vaccinations done. Whole office education. We know that it's not just what the physician or the provider is saying, but it's sometimes what the front desk or the MA or the nurse is saying as well, and making sure that every person who has contact with someone who's inquiring about vaccines has the right information and is making those strong recommendations. And then we have the opportunity to shift the conversation completely, which is really what this webinar today is about. Next slide, please. So there is a growing enthusiasm to shift the initial HPV vaccination from the 11-12 visit down to age 9. That's something that's recommended by AAP. They recommend starting the series between 9 and 12. And then the ACIP, the Advisory Committee on Immunization Practices, their recommendation is starting the series at age 11 or 12 years, but that the vaccination series can be started beginning at age 9. So both of these entities recommend that children can be vaccinated against HPV as young as age 9. But there's a subtle and important difference in the messaging of these two recommendations. And because so much in EHR and from immunization information systems is based on strictly on the ACIP recommendation, the difference between these two recommendations can sometimes make it difficult for the systems that we work in to provide the prompts and the forecasting that's needed to recommend that the 9-year-old that you're seeing is actually due or recommended to get an HPV vaccine. And because of the differences in these recommendations, there can sometimes be confusion amongst clinicians and parents. And parents might hear that their 9-year-old can get an HPV vaccine, but call the provider's office and be told by someone at the desk that, no, we do that at 11. Or there may be providers who are hesitant to give it for fear that maybe insurance isn't going to pay for the vaccine, or that they would be going against official ACIP recommendations. Next, please. So AAP recommends initiating the HPV conversation as early as age 9 because of several reasons. One, it reduces the number of vaccines at the 11 and 12-year-old visit. Those vaccines are now HPV, Tdap, tetanus, diphtheria, pertussis vaccine, your meningococcal vaccine, and then depending on the time of year, that might also be seasonal flu and COVID vaccines as well. So maybe 5 vaccinations that would need to be given at the 11, 12-year visit. Moving HPV up to age 9 would reduce the number of vaccines that child would need to get in that appointment. It also allows them to get the entire series finished before they even get to the 11 to 12-year shot visit. There really isn't a documented clinical downside to giving HPV vaccine at age 9. We know that the immunological response is still very robust and longstanding. It is sometimes easier to disentangle the conversation around the sexual transmission of HPV if those conversations happen earlier, when parents really aren't even thinking about sexual activity in their 9-year-old. And so we can really talk about how this is cancer prevention, and we don't really have to get into necessarily how HPV disease is transmitted. And then it gives just a longer on-ramp to complete the series before age 13, which is when we really want to have these children fully vaccinated. So even if the parent says no at 9, it still gives opportunities at 10 and then 11 and 12 to get that conversation, to get that child vaccinated and to get them finished before they turn 13, which is the goal. Next, please. So I'm going to turn it back over to Gabby and the other presenters who are going to talk about what they've done to be able to help to forecast HPV at 9 in their particular health systems. And I'm excited to hear what they have to say as well. Thanks, Gabby.
Oh, thank you, Shelley. That was the perfect introduction and level set to our conversation today. And we're so excited that we had not just our co-chair, but obviously someone who's working in the field as a pediatrician and clinician help give some of the just basic information as to why we're here today. So I also have the pleasure, so thank you, Shelley. I also have the pleasure of introducing our second presenter. Our second presenter will be Dr. David Barshane. He's the Director of Informatics at Metro Health and will be presenting on the topic of HPV vaccination or HPV vaccine, optimal early start at age 9 or 10, an EHR case study. Let's go ahead and welcome Dr. Barshane.
Thank you so much for the opportunity to present. So I'm David Barshane. I'm at Case Western Reserve University and Metro Health in Cleveland. and I want to share with you what we've done to support the early start. However, I'm having trouble advancing the slides. So maybe I'll just have to ask for the next slide, and the producer will advance for me. There we go. Okay, I think I got it now. So our learning objectives for my segment are to describe how we implemented health maintenance for HPV vaccine early start at age 9 or 10 in our instance of EPIC at Metro Health, to discuss the impact of the change on our population, and to review some lessons learned and ongoing challenges. A high-level agenda, I'll take you through some introductory words. I'll show you what we built. It's not a very technical discussion, but just want to show you some screenshots and explain what we did, take you through some outcomes, and draw some conclusions. So let me start my words of introduction with words about Metro Health, where I work. So Metro Health is an Epic Enterprise customer. That means that we care for patients in the Epic Care ambulatory EHR. That's an Epic product. We provide a patient portal called MyChart. That's an Epic product. And we can report out of Epic using tools like Clarity and Slicer Dicer. Both of those are Epic products. Regarding vaccinations, we provide patient-specific forecasts to providers via an Epic module called Health Maintenance, and we allow patients to see their own forecasts in MyChart, the patient portal. And then we were able to leverage some organizational assets, including our collaborative culture, our long history of optimizing and customizing our EHR, and the fact that we allow subject matter experts, such as myself, I'm a pediatrician, I'm also an informaticist, to make changes under the system. So this was a clinically driven change. Experts in the Department of Pediatrics came to me, and we collaborated to make this happen in our system. We had 4 issues that led to 4 project goals. Spoiler alert, we were actually able to solve all 4 of these problems. So the first problem is that we know this, some adolescents don't complete their HPV vaccine series before their first potential exposure, before their first intercourse. And so our goal here was to increase opportunities to complete the series by encouraging an early start at age 9. Our second issue is that we didn't want to reinvent the wheel by duplicating standard Epic functionality. So if Epic provided something, we wanted to use that. And our goal was then to create functionality that complements but doesn't duplicate the standard, what's available to us standard. Our third issue is that not everybody wants to start early. So some parents and providers don't want to deviate from the official start age, the ACIP official start age that Shelley talked about of 11 years. So our goal was to clearly indicate the optional nature of the recommendation. And our fourth issue was a question, how do we detect if we're making a difference? And here we had to get creative and use some apples to apples reporting strategies, which I'll take you through. So again, I'm not going to take you through the technical details of what we built, but I just want to explain a little bit about health maintenance. Health maintenance is a periodicity engine. It's our forecasting engine. It provides the patient-specific forecast. And on a schematic level, health maintenance is divided between a topic and a plan. So if I talk about a topic, the topic answers questions like, what is due? Are we tracking MMR vaccines? Are we forecasting colonoscopy? Are we forecasting mammograms? What age does it start? How frequently is it due? The choices there could be, it could be due once in your life. It could be due every 10 years. It could be due on some kind of an idiosyncratic schedule, which is what the immunizations look like, with minimum ages and minimum intervals and recommended ages and things like that. And then another question that's answered in the topic is, should patients be able to see the forecast in MyChart? And as an adjunct to that, can patients self-schedule via MyChart? So that's all contained within the topic. And then when we talk about the plan, we're talking about something that hugs the patient to the topic. So the plan answers the question, who should be exposed to the topic? So high level for this project, we have 2 topics, and each of those topics has its own plan. I'm calling the EPIC release topic that begins at age 11 the standard topic. You'll see that word come up on the slides. And then what I built and what I'm presenting here is the optional custom topic, which begins at age 9. And each of those, like I said, has its own plan. So This is what it looks like when the provider signs in and accesses the health maintenance module for a 9-year-old. This is all synthetic data. There's no PHI on the screen here. And the provider can see that there are care gaps. There are some called current care gaps, and there are some called upcoming care gaps. And among the current care gaps is the HPV vaccine optional early start at age 9 or 10. It's a mouthful, but it says the word optional, so we got that goal achieved. And if you keep going across on that row there, you can see a red icon. That means it's overdue. So the patient has passed their 9th birthday. It's never been done. And if you keep going all the way to the right, that clipboard with a plus icon on it, that is a button which allows the provider to queue up exactly the right order. And then in the upcoming category, we have HPV vaccine dose 1 of the male 2-dose series, and that's what I'm calling the standard topic. And that due date isn't due until January 1st of 2026, which is the 11th birthday of this synthetic patient. So it's due in the future. So on the same screen, the provider can see that something is optional that you can do now, and something is coming up, which is when it's officially recommended by ACIP. This is what happens after a 9 or 10-year-old gets a dose. So the optional early start topic is completed and it melts away. We hide it. You don't need to see it anymore because you've already initiated. And then the standard topic takes over. And the Easter egg that we're taking advantage of, the hidden secret here, is that the standard topic is happy to forecast the second or subsequent doses according to the regular schedule without regard to the patient's age. So even though it wouldn't forecast the first dose until they're age of 11, for a second or third dose, it's perfectly willing to forecast it before 11. And so the standard topic takes over and says that this patient is due for dose 2 of the male 2-dose series. This is what it looks like for the patient when they sign into my chart. So a parent proxy for a 9 or 10-year-old can access the preventative care page for their child, and they'll see current preventative care reminders. And among those is an overdue topic. So this is like a tile that says overdue is HPV vaccine optional early start at 9 or 10 years. And there's a little schedule button there which will allow them to schedule according to our business rules. So it allows a 9 or 10-year-old to be scheduled either with a nurse or a provider as is appropriate. And then in addition to that, on the same screen, they can see that something is not due, which is the HPV vaccine. And that's not due until January 1st of 2026, which again, for this synthetic patient represents the 11th birthday. So both the optional and the standard topic will appear on the screen at the same time. This is an overview of a timeline of decision support for HPV vaccine at Metro Health. In 2006, I think, is when ACIP first recommended the vaccine for girls. 2012, Metro Health went live with health maintenance for pediatric vaccinations, including HPV vaccine. At the time, everyone was getting a 3-dose series. I think in 2016, ACIP recommended a 2-dose series for low-risk people and a 3-dose series for high-risk people and people who started after age 15. And so we had a major upgrade to our decision support to forecast correctly for everybody. 2020 is when this optional early start topic began. And then in 2023, I mentioned that we allow patients to self-schedule for their vaccinations. That's when that began in 2023. Let me take you through our outcomes. So here I'm going to share data from 3 different data sets. The first data set came from Slicer Dicer and is just looking at about the last 5 years. And Slicer Dicer allows us to include encounter data along with immunization data. That's why we were looking for help with the Slicer Dicer. And what I'm showing you here is our HPV vaccine completion rates for all our 9 through 18-year-olds who began the series in a primary care visit at Metro Health since January 2020. The blue bar are the complete, and it says now green, but the legend is wrong. It's the orange bar is not complete. So about 60% of our primary care patients who started the vaccine, who have started the vaccine since 2020, are complete, which means we've got a lot of work to do. About 40% have not gotten their final dose yet. I want to take you through a little bit of a longer analysis going back to really the beginning of time with January of 2006, when on or about when ACIP started recommending HPV vaccine, and take you all the way up through the present. And here we can see two different secular trends in the data. So what we're looking at on this slide is the trend in completion rates by the year of initiation. So on the x-axis on the right side and on the left side in those two plots, you've got the year of initiation, and on the y-axis, you've got the percent complete. The left group are people who initiated at age 9 or 10, and the right group are people who initiated at 11 through 18. Again, the legend is wrong. The blue bar in the figure represents complete. The orange bar represents incomplete. So the first secular trend you can see here is that the amount of each bar that's orange has gotten more. So we're getting worse. We're completing fewer people in the most recent years compared to what we were historically. Historically, up through about 2020, we were running somewhere around 75% completion. And just since 2020, we've been running lower at about 60% completion. That jives with the slicer-dicer data that I showed you on the prior slide. The second secular trend that I want to share with you from this longer analysis is that we're getting better at immunizing the younger group. So here we're looking at the year of first HPV dose, and we're looking, the denominator are patients who began the series since 2006. And on the y-axis is the percent of patients initiating the HPV vaccine, and we're stratified by age. So the orange represents the 9 or 10-year-olds, and the blue in the figure, again, ignore the legend, the blue represents the older cohort, the 11 through 18-year-olds. And so you can see that the orange bar is growing since 2020, and that coincides with when we introduced the optional early start topic. And then I want to do a focused analysis just on the last 5 years where our completion rate had gone down, and ask some interesting questions about what happens when you start early versus starting late. So I'm saying starting early, 9 or 10, and I'm saying starting late, 11 through 18, but late isn't really late. According to ACIP, you're supposed to start at 11. So here we're looking at percent complete on the y-axis, and this is every 9 through 18-year-old who began the series since 2020. And what I notice here is the blue bar represents how much of that subpopulation is complete, and it's roughly in the same range, right? So it's high 60s for those who initiated at 9 or 10, and it's low 60s for those who initiated 11 through 18. So maybe it doesn't matter so much if we start at 9 or 10. That's a hypothesis you could posit. So overall, we had 24,000 patients 9 through 18 who started their HPV series since 2020. About 5,000 of them, 22%, were younger. 78% of them were 11 through 18. And the older group had a slightly lower rate of completion. That's the smaller blue bar. Here we're looking at patients who began the series since 2020 who are 9 through 18, and we're looking at the age of completion. So completion, the age at which you completed. No, I'm sorry, the age at which you initiated, that's on the x-axis, and the percent is the percent who are complete. So what you notice here is 9 through 14 have roughly the same completion rate. The blue bar is about the same for all of those. But there's a drop off at 15, so 15, 16, 17, their completion rate is lower. If you start later, you complete less, or at least in this data set you do. So that's an interesting thing. But if you look at 9 and 10 versus 11 and 12, there's not such a difference. So again, maybe this hypothesis, the null hypothesis, that it doesn't matter if you start at 9 or 10, maybe we should just start everybody at 11 or 12. But I think the answer for why you should start at 9 or 10 comes from the next slide. This is, or comes from the next two slides. These are the money slides. So I was curious, how long does it take you to complete? If you're going to complete, how many months between your first dose and your final dose? So we're looking at everybody who began, everybody 9 through 18 who began since 2020 and has completed the series. The orange line on the graph is the 9 or 10-year-olds when they started at 9 or 10, and the blue is starting at 11 through 18. On the x-axis is the months from first to final dose, and on the y-axis is the percent complete, and that's a cumulative percent for that subgroup. So both of the subgroups reach 100% because that was the denominator. Everybody in this data on this slide has completed. And what's remarkable to me is the overlap in those lines. I almost didn't believe it when I saw it. And I went back to the raw data and I said, yeah, those really are different numbers. So it takes about the same number of months from beginning to end of the series. And I highlighted there that it's in our sample, it takes about 25 months to reach 90% of that subpopulation. But this is the money slide. If you start earlier, you complete more of the population earlier. So on the x-axis here, we have the age in years of the completing dose. On the y-axis, we have the cumulative percent complete. And again, both groups are reaching 100%. The orange are the people who started at 9 through 18. The blue are the people who started 11 through 18. And I just want to highlight 2 points here, which is age 13 and age 15. At age 13, if you start with the younger group, you've achieved 99% completion. Whereas there's a gap. If you start at 11 or 12, only about 65% of the group is complete. And at 15, the gap narrows. It's about a 13% gap. If you multiply out the numbers, so the gap by the sample size of the 11 through 18-year-olds, you could speculate that if you had started the older kids at a younger age, it's possible that 6,000 more people would have been completed by the age of 13, and 2,500 people would have been completed by the additional people would have completed by the age of 15. And I didn't choose those 13 and 15-year-old ages arbitrarily. I chose them because clinically they're relevant ages. In my experience as a general pediatrician, many of my patients become sexually active and experience their first potential exposures to HPV after the age of 15. And a minority, and it's a small minority, but it's still a real minority of people, begin at 13 or 14. So what I conclude from this slide is I don't know who's necessarily going to start early with their potential exposures, but if I start vaccinating them earlier, I may achieve a higher rate of completion for those people who are going to start early. So let me just spend the last minute or two drawing some conclusions here. So we were successful at implementing an HPV vaccine optional early start topic at age 9 or 10 in our system. We allow providers and parent proxies to see the forecast. Proxies can use MyChart to schedule a visit, and providers can order from the care gap itself. We know that some patients started early. Since the optional topic began in 2020, overall, about 22% of our vaccinated patients have started at 9 or 10. And that proportion has been rising of the people starting at 9 or 10, and we're up to about a third now in 2025. And comparing the early versus the standard start age, so we found approximately equal final completion rates since 2020. That was about 60% at Metro Health, approximately equal months to completion. So it took about 25 months to immunize 90% of each subpopulation. But we also see that earlier start means earlier completion for a larger portion of the population. And we know that earlier completion means better protection for those kids who are going to be exposed earlier. And we did uncover some problems, which include that many providers and patients don't seem to be taking advantage of the early start option. We had some difficulty to report on the outcomes, and compared to our historical levels of around 75% completion, our recent rates since 2020 have declined. So we've got some pandemic and post-pandemic catch-up work to do to overcome resistance and get people into the clinics. These are a short list of references. That fourth bullet point there is a technical guide. Epic interviewed me and wrote up a technical document, which is a step-by-step build guide. So if you're an Epic customer, you can access this document on what Epic calls its user web, and you can see step-by-step build instructions that will allow you to implement an optional early start topic in your Epic system, very similar to what I built at Metro Health. And I'll stop here. Thank you so much.
Awesome. So thank you so much, Dr. Barshane. Such exciting outcomes that you saw. I was stuttering to get back on screen because I was just shocked by your slide that talked about if we start at age 9, we can hit this many adolescents by age 13. And then if we start at age 9, this is how many we can even reach by 15. So that's such great outcomes to see based on the work that you guys are doing. And so I know we have some questions coming in the chat. Keep your questions coming, guys. We have a very immersive Q&A at the very end from all 3 panelists. And now I have the honor of welcoming our final presenter for today, Dr. Thomas Shook, or TJ as we like to call him. So Dr. Shook is going to be presenting, or Dr. Shook is also the Chief Information Officer at South Boston Community Health Center, and he will be presenting on the topic of preventing cancer through HPV vaccine EHR case study. Let's go ahead and welcome TJ.
All right, thank you. It's my pleasure to be here today and share a similar story, also from an EPIC instance, but a little bit different pathway than David. So I'm going to walk through how we implemented our 9 is fine strategy in our EHR, how I use continuous improvements to meet those goals, and share some of my own lessons learned as well. So my disclosures is that I think, like probably all the pediatricians on this webinar today, we love vaccines and especially love informatics to make maybe complicated workflows possible. So I'm here representing South Boston Community Health Center. We were founded in 1972. We're part of the proud urban community health center movement in the United States. We have 3 clinic sites with about 60,000 visits in a year. So we're smaller compared to a larger hospital system, but we're a fairly qualified health center who does really pride ourselves in being a teaching facility amongst most of our job roles. And we use EPIC via the OCHIN Community Connect model. So just to highlight, even though Shelley shared earlier, we're here in Massachusetts. We're one of the highest states maybe for HPV vaccination. But that sort of completion metric by 13 years old shows that, one community health center, that's only one slice. So within even a state, there are disparities that exist. And so we're proud to be leading in Massachusetts amongst community health centers, but there's still gaps across spaces. And then my overall inspiration for what I like to build into the EHR is always trying to make sure that whatever you're building out, making sure there's good data that we're putting into the system so that we can pull good data out, as Dave has already shown. One of the other key pieces is that, everybody loves sort of trying to think about building in alerts, but making sure that those alerts are built in with the 5 R's so that you're giving people the right information, it's going to the right person with the right intervention through the right channel at the right time. You can pick your favorite S at the end of KISS, but keeping it simple, and then also trying to use a philosophy of Maya, which is building things that are quite advanced, but in the end, it has to be acceptable to your staff, right? So I could build lots of bells and whistles, but people have to be able to digest it and still use it. And then finally, it's not just build something and mic drop. You need to continuously be monitoring your tools and have that idea about continuous improvement. So our journey really started with a more traditional QI project. There was a researcher that came to us to try to increase HPV vaccination starting at 9. And so as even Shelley mentioned, right, when you're all hands on deck and you're doing a QI project, you're usually going to do all these things with educating providers, educating patients, making standing orders, trying to do all these things to chip away at barriers. But I knew underlying this, I wanted to get that preventative care reminder to turn on HPV at 9. And so initially we had to do that in EPIC, they're called best practice alerts or our practice alerts. So first we had to just do it kind of as a reminder that, hey, there's that standard topic, but you should have that discussion earlier. I'm not going to show it, but what we evolved to is actually just, again, using what is EPIC standard and using a health maintenance modifier to just turn the topic on at an earlier age. And then we also tried to then take a very strong approach at our facility that we wanted every visit to be a vaccine opportunity. And that was something we committed to as a cultural change. And so what I'll show in some of my analytical slides is that I think, traditional QI efforts, those things are all great. But I think what has really panned out is that being able to build things into the EHR has allowed for sustained improvement outside of the traditional QI period. And so this is a picture of the alert that we built. I'm only wanting to highlight that this is part of this 5 R's is about, it's not only alert to show that somebody's due for the vaccines, but showing the breadth of the vaccines that they're due for, making it easy. It's not just, hey, they're due, I help direct them to an order set where they can order all the vaccines that the patient's due for in one tool, rather than having to, oh, they're due, let me go pick something from a choice list. But then in the bottom, you can see that little red stop, that this is part of that getting good data in. We realize things happen, maybe it's a physical, there's 5 other things you're dealing with, or sorry, not a physical, or there's other things you're dealing with, but every touch we have with the patient is an opportunity to either get outside records, schedule a physical. And so by requiring the staff to help give us data about why they didn't vaccinate, it makes looking at those missed opportunities much easier and allow training back to certain staff. So this is my first analysis of our project. This is a control chart, which is a type of data analysis tool, where that on top of a normal run chart, you can show what your statistical performance is over a period of time and average that, which is what the black line is. And then you can set control limits, which are the 2 and 3 standard deviations away, to kind of give an idea of, are you doing really well? Did you get past that 3rd standard deviation? Are things, not going well? Were they getting in the negative 3rd standard deviation? So I have those colored as red and green to highlight that. And so, again, another good thing, if any of you are looking to start to do one of these projects at your own institution, is I also, had run-in data, right? So this graph was the initial short-term outcome, which was for people from 9 to 18-year-olds that we're seeing every month, how many are we getting completed on the HPV vaccine series? And so initially, you can see in the run-in period, it just depended on who was coming in that month. But then I think what has been shown really over and over again, just doing that provider education, having everybody come together, repetitive meetings about HPV, got that to be at the top of their mind. And so just in talking about it, the clinic saw a bump in performance of HPV vaccination rates. And then, building the tools, this is, Dave and I aren't sharing all the secret sauce, but that, it takes time. It's a lot of things that we're in the background doing. So that took, even almost a year to get in, to pilot, and then scale up. But what I'm trying to show then is after those tools, again, I don't know if it's coincidence, but as I'll show, continuing to monitor things, we've just seen sustained improvement over that time. And that's what led to me personally getting the 2019 HPV Vaccine Champion Award for the state of Massachusetts. Okay. And so from there, I want to highlight that, right, we did the QI effort. I get some build in, but then, it even took another 2 years to get that modifier to have HPV start at 9. So for us and our approach, we didn't want to say optional. We wanted to say we want to recommend everybody start at 9 years old. But then I think having these tools in, and especially setting that forecasting right away, we also operationally during COVID prioritize all those kids coming back for vaccination, or at least prioritizing those. Oh yeah, David from the chat. It's we are using Epic, so that was a earlier picture from Epic. I also, as the Epic software was changing, the way these BPAs fire also made it so that they were being missed during visits. So again, tried to make efforts to change them there. And again, just kept always trying to chip away at any reducing missed opportunities. So I want to just highlight, a lot more of this is just about how I kept analyzing the system. So this is again another control chart about how we're doing with vaccine orders over time. And so similarly, during the QI effort, orders really went up. Before COVID, realized that there's also seasonal variation in vaccination. So the more traditional physical season from the spring to summer, vaccination rates always went up. During respiratory illness season, vaccination efforts went down. You can see during COVID, as I mentioned earlier, we were prioritizing bringing those kids in. So we had, of the kids we were seeing, a much higher percentage were getting HPV vaccine. And initially I can say, when I look at this, one way is to say, oh my, we're not getting better at vaccinating, right? Of the 9 to 18-year-olds we're seeing, we've been staying at the same pre-intervention level of the vaccines that we're giving per month. So what I want to highlight is that one of the other continuous improvement things is that the sort of process or short outcome metrics that I was starting with, I've been constantly trying to evolve. And David and I even had conversations prior about, especially how to prove that the early start leads to better outcomes. So one thing I did is I just looked at, okay, what about for our 9 to 10-year-olds? Have any of them gotten a dose of HPV? And so what's great with this control chart is that I can feel good that 54% of our 9 to 10-year-olds are getting an HPV vaccine. So that feels great. And then I tried to, again, the manipulation of that data to those control charts, that takes time for me. So as Slicer Dicer in Epic has gotten better, I've been trying to move my reporting into there so it's easier to tell these stories, to get them into hands of other operational staff or other providers to look at discrepancies and what's going on. And so with this graph, I'm trying to tell the story of, again, what we would say is, what we want to become the new starting dosing of 9 to 10 years old is the green bar, 11 to 12 is in blue. But this is looking at all the HPV vaccines we give in a quarter. And so what you can see is here I was on the far left, starting to give HPV at 9 before the whole health center was. Then we did the QI effort and saw the bump. And then just before COVID, which is that obviously where everything tanked to zero with that line, we were starting to flip the script. And what's amazing is that after COVID, we really, our group has, the predominant vaccine, the age that we're giving vaccines to is 9 to 10 years old. And I can tell you that's not because I'm outside on the floor. I've, changed job roles and becoming the CIO at the health center. It's not because I'm onboarding all the new staff, right? The staff that were there for that QI project have all sort of turned over. And so again, something else is at play to keep this sustained effort. And so one thing I tried to do is there is data in Epic itself that it knows what age the kid completed the health maintenance topic. And so in this case, I built some reporting tools within Slicer Dicer to try to have it tell me that age. And so this is this graph is looking at of the kids we saw during a calendar year, what was the average age of vaccine completion? So again, this is going year by year. And again, I can feel really great to see that back all the way in 2016, it was 14 years was the average age of completion. But then throughout this last decade, we've been able to drift that down to 11 years old. And then this is a more complicated slide that I'm not going to highlight a lot on and try to go to the next one. But within Slicer Dicer now, you can also do pivot tables. So it's called crosstabs and slicer dicer. And so again, I kept wanting to chip away at looking at their immunization model, like David, looking at what age we gave a vaccine compared to which is on the left side, and then across the top is what age the kid completed. And like David showed, the red arrow there is, the later we're starting, the less likely you are to have completed your vaccine series. So I tried to then group that together into those bands of sort of 9 to 10 preferred start, 11 to 12 standard start, and then 13 plus being a late start. And again, we're a smaller institution, but of the 1,200 doses, again, over the last 9 years that we've given to 9 to 10-year-olds, if you add up these percentages, we've been able to complete 82% of them are completing by 12 years old. Okay, so if you get to that 13-year-old, then you're not meeting that HEDIS outcome metric of complete vaccination by 13. Compared to those 1,000 doses that we're giving to kids at 11 to 12, only 67% of them are completing by 12. All right, just even this last month, I saw a kid come in at 12 and a half for that 11 and 12-year vaccine. So, and that was the first time they got their HPV vaccine. So, they're really unlikely to complete by 13. And so again, every reporting outcome metric has its pros and cons. So the CDC Vaccine Champion Award is also doing this quality, looking at this for quality improvement as well. There's also all these different, as has been presented today, many different outcome metrics on this, which can make it sometimes difficult to compare. But again, at least I wanted to, and I started tracking as well that CDC outcome. And so again, we've had this sustained improvement. Things have been going down, but I'm again trying not to get too much on myself because we're still at 84%, right? We're staying above the 80s, which is above the threshold. So for me to wrap up, I would say the lessons learned is obviously I've been passionate about this work. So having a champion to sort of continuously helping to look at look at your data, look at the processes, that always helps. I think the story I like to say is that my effort of putting these clinical decision supports in for my institution has helped reinforce that this is the new normal and that it's not required onboarding training or this has just become the new normal because all the decision support in the EHR is saying start at 9 and try to vaccinate at every visit. And so I think that means, if you're going to make that strong recommendation from you as a provider, that's why also making that strong recommendation in the EHR. As David also mentioned, by turning on this in your, making sure your patient portal also brings that awareness to patients. So they can maybe, the ones that are most engaged in the portals might see that as something that needs to be addressed, or they know before the visit, or we know how, once they're outside of the visit, life takes over, but the portal can give them that reminder that maybe they're still due for a dose. And then finally, I think as we both showed that using analytics is really important to just reinforce your build because trainings and alterations in the software, blasting out reminders always isn't great, but you can now, if you have analytics, instead of blasting out an email to the whole department, you can go to the individuals who are maybe lagging or look at what else is the disparity in groups that are lagging compared to the rest. And then obviously, again, I've been evolving what metrics I'm looking at, but it helps, it helps give a fuller picture rather than only relying on one metric. All right, thank you so much.
Awesome. So thank you so much, Dr. Shuck. Thank you so much, Dr. Fiskus, and thank you so much, Dr. Barshane. I would like to invite all of our wonderful presenters back. I don't know about you, but I feel like there's such good energy around the presentations today, all of the information that's learned. I'm like geeking out over here because I have so many questions. And then I look at the chat and there's so many questions that have come in. So we're going to do our best to answer and prioritize all of the questions that have come in and have not been previously answered via the chat and via Q&A. So now we will turn over to our Q&A part of the event. If you have other questions, feel free to continue to send them in as we're having this conversation with our panelists, and we'll try to integrate them as best as we can. So again, thank you to all of you for taking the time to serve as our panelists for this session. I don't know about you, but there's such great energy about just the information that you've shared. So we've shared. I haven't presented nothing, but y'all have shared great information on the great work that you guys have done. So we're going to start first with Shelley. So we had some questions around ACIP specifically, and I know I saw you started to answer some of those questions in the chat. So one of the first questions that we got, are groups advocating for ACIP to change its recommendation language from can be started to recommended, and do we anticipate that change soon?
So there has been some advocacy for that. The HPV work group for the ACIP had been decommissioned some time ago, but has now been reassembled. And this is actually a topic of conversation that was going to be discussed, I think, at the next ACIP meeting that was supposed to happen in February, but has now been postponed. So don't really know what's going to happen with that meeting, when it's going to be rescheduled, if the agenda is going to look the same once it is rescheduled. But those conversations have been happening, and I think there was some willingness to consider that. So we hope those conversations can resume to just streamline the recommendations and take away some of that confusion.
Yeah, I agree. Yeah, so until it's re-engaged for the meetings, we're trying to figure out some workarounds, and this is why we thought that this webinar would be a great, not a workaround, I think it's just a workflow prioritization, but this is one way that we can still make sure that H9 is prioritized. But yeah, ACIP language would help us a whole lot, and unfortunately that's out of our hands, right, for right now. So the follow-up question was on when they will be meeting. And so right now it's a TBD for those who asked those questions. And when we find out more about when they will be re-engaged, we'll definitely make sure that you guys know more about when that engagement will happen. So Shelley, one more question for you. Coming to this work as a clinician and pediatrician, and now leading the immunization managers, how do you foresee, or how do you anticipate some of these EHR H9 workflow changes really impacting the role of immunization managers in your work in that respect? If you could answer that question. Yeah.
Well, I think there's some good opportunities for immunization programs to work with large health systems that are instituting this, because there's a potential environment where your state's immunization information system or their immunization registry would be forecasting HPV vaccine at 11, where a local health system EHR might be forecasting it or suggesting it at 9. And so there's potential for some synergy there. Sometimes there's barriers because of the difference in the language with ACIP that impedes the IIS to be able to move to that kind of forecasting. Other states have been able to do it successfully. Some of it depends on who their IIS vendor is and whether or not they can make that change for a particular jurisdiction, or if they have to make it for all of the jurisdictions. So they all have to be on the same page. But certainly it's exciting to see that there are health systems that are able to do this for their particular health system. And it's really important to share that information so that if there's issues with the IAS being able to forecast down to H9 and a health system wants to move forward with that they know that there are some opportunities to do that, like what David and TJ have shared today.
Awesome. Thank you so much, Shelley, for answering those questions. So I'll shift over to David and TJ, and this first question is going to be for David. And one of the questions we got is, can you tell us more of the process of making the EHR changes to start at H9? So what did that process look like, and what are some of the barriers and facilitators to that process?
Well, so I mentioned that I'm a clinician, and there was a senior member of our department who requested this change and brought it up with another informatics physician and myself. And I said, yeah, I think we can do this. And it took about an afternoon to sketch it, and about a month to implement it, to get all the approvals necessary and think through all of the different issues. But it wasn't a lot of EHR work, not a lot of informatics work. I've certainly done much more complicated immunization projects than this one. Oftentimes the window dressing is what takes the most amount of time. So the forecast itself was very easy, but getting the right order to populate and figuring out how to show it in my chart, those involve different teams. So I needed to collaborate with the orders teams and with our my chart team. Um, and mostly it was cultural. Mostly it was selling it to our end users. And like TJ said, that the folks who were there for TJ's quality improvement project are no longer at the institution. And it's pretty much the same thing in our institution. There's a lot of turnover, new providers coming, old providers leaving, young providers leaving, nurses coming and going. And so we've almost rebuilt the entire staff. I've been a constant, but we've almost rebuilt the entire staff in those years. And the nice thing about having it embedded in the fabric of the EHR is the EHR just continues. So even if the champions leave or lose interest, then the EHR is still continuing to give the nudge.
Okay. So it seems like you've identified some key barriers, obviously cultural and staff changes, right? So people leaving, which is what we anticipate in any type of organization. Are there key facilitators that you can identify outside of the ones that you previously talked about that you think really helped push it? Obviously outside of the system itself, right? Epic and how the build was integrated.
Yeah, so it's an interesting question. So as an informaticist, and a clinician, I can go rogue and build things that I think are right, and sometimes I do that just on my own recognizance. In this case, it was almost a policy change. Are we going to, as a department, as a hospital, are we going to change this? And when I changed it for peds, it also changed for family practice and med peds, everybody caring for children. Anybody who's consuming the forecast will see this. So those key stakeholders included leadership for me, the people requesting it, and then the people on the ground who are in the trenches, in the clinical trenches, giving the care. They needed to hear something about it and know that this was an acceptable option. So other clinicians who were going to be introducing the idea, nurses who have to get on board with, oh, I got an order for a 9 or 10-year-old to get an HPV vaccine. My training says that that's not okay, so educating those people to say, no, that's actually a valid order and it's going to count in health maintenance. So so those were some of the folks that we engaged. We haven't done a lot of push with parents and proxies other than in the clinic on a one-on-one basis. We haven't pushed out a lot of information to parents in general through my chart or other means. That just, I don't have the means to do that. And it seems like it's diminishing returns.
Okay, awesome. Thank you, David.
Sure.
TJ, same question for you. I know you talked a little bit about the timeline for you in your presentation. I did pick up on that. Can you talk more about the process of making that change within your health system, and if there were any barriers or facilitators that existed? Yeah.
Yeah, I guess I would say, right, part of the expanded timeline is because I took the opportunity of building an alert for HPV vaccine at every visit to layer on top of that hey, every vaccine is important, right? We've got as a federally qualified health center, we have a recurring outcome metric about vaccine completion by 2 years old, so that I was trying to take this grant money to then help give that investment in my time and energy to elevate every vaccine at our health center. And so I think not everybody may have a TJ or David, but I think what I at least hope everybody realizes is that these changes are possible, and it may just be needing to find the right person, right? I guess my hope is that everybody has an EHR that is modifiable in some way. It may just be needing to know who the right person is to ask, right? Just like I imagine every IAS could probably also change their forecasting to start at 9. It's just that who's that decision maker that makes that decision. And often, and sometimes pediatric decisions are not prioritized at institutions, but that either way, sometimes part of that core thing is figuring out who is that decision maker who helps decide about making changes at your EHR. Because you may not, you may need to build up your training if you want to do that as a clinical informaticist. But I think also over the last decade, clinical informaticist has been growing. There's a board pathway to do that. There are more training programs to do that. What else was I going to say? And the other thing is that not every state has a bidirectional interface with their IAS. And so again, I'd also really hope if your EHR does not have an interface with your IAS, that, very few of us have a closed loop system of patients, right? Our patients move from facility to facility. And, obviously if you've got immigrants, that's a different problem, but about getting those vaccine records. But being able to have those connections is really important, so that you're also reducing barriers about, I got to go log into a different system to find outside vaccines. And so even just there's always, there's many ways to approach this, I guess is what I'm trying to get at. And it's just, everybody's got their own EHR issue, their own maybe IAS issue, your own staffing or training barriers. I mean, I've even heard of some states that the Vaccine for Children program doesn't even allow for funding of HPV starting at 9. So again, we all have our constraints that we have to work within. But I think, if you love this work, then it's just trying to pick away at what you can modify.
Okay. So I think what I got from you is that you took into consideration not just HPV, but all vaccines, and creating the culture as early as starting at the ages of 2, so that by the time they get to the age of HPV, that it's kind of built in the system that kind of helps propel and push those vaccines forward overall, all immunizations. And then I've also learned that I can be an informatics specialist.
Yep.
I just need to go and figure out some special training program. But every EHR system is not going to look the same. And even between you and David, there may be small tweaks and differences between your health system and the patients that you serve. And so those are some special considerations and facilitators. I think one of the questions that we always get is, and we know this is a custom build. This is Epic, and then you guys decided to integrate H9 into almost like a custom or a separate build. Is there a cost consideration that should be considered when you're thinking about, like, how do I optimize my EHR system for H9? And how do you have that conversation with leadership to make sure they have that buy-in into investing, if that is such the case? David?
There's a cost for everything, right? But everything is possible with enough time and money. Someone once
Yeah.
told me that.
Yeah.
I'm fortunate to work at Metro Health, where our mission is this is concordant with our mission to try to increase HPV vaccine uptake. And as I said, it was leadership in our division that requested it. So I felt like there was a mandate to use my limited time and resources to work on this project. But as an informaticist, I said it before, and I'll just emphasize it again, the step-by-step actual under the hood building was done in the course of an afternoon.
Okay.
The more time-consuming part is pushing it across the finish line. So getting the layers of change control approval from the folks who govern the EHR, and the cultural changes, the dog and pony show, to go and sell it to people in the trenches. But we felt like even if we didn't reach everybody with our messaging, the nudge was going to be there in perpetuity within the EHR, so it was worth it. So I think we've gotten a good return on the investment. I don't know how you would have a dollars and cents kinds of conversation with it.
Mhm.
I would more appeal to it's the right thing to do and it's not a heavy lift, and leave it at that. If somebody were coming to me with really resource constraint and I wanted to do this, that's what I would say.
Okay, TJ, same question for you.
Yeah, I think I'd only add that also that, right, we're sharing longitudinal, things that are maybe over a decade's worth of experiences, and so again, there's some investment up front, as I mentioned, but then I think it's more about realizing, right, figuring out little PDSA cycles, little continuous improvements to just keep in those bandwidths of time to especially if you're the champion on this. I think that's that part of that internal drive that I think that if you're identifying yourself as a champion on this, then like you want to see it improve. And everybody sort of gets at least some admin time on top of their clinical time, so that if you're passionate, that right, you're putting the energy, and it's just part of standard operating practice, as David said. We as pediatricians want to get those shots in arms. So
yeah. So another follow-up question is, we talked about the investment in it, and we had a question about if you're in a rural community, maybe an underserved, under-resourced community. So how do you get a QI project like this off the ground, where there maybe have to be some cost considerations or other considerations? So how would you get a QI project? And I know, TJ, you had talked about your QI project, so I'm gonna ping that question to you. So how do you get it off the ground and running?
yeah, I mean, so part of that was starting that, again, a researcher came. So the researcher had found the grant opportunity to help push that, be that push for the QI effort. I think, again, as Shelley's chiming in, right, the VFC program for kids, at least the vaccine being available, there shouldn't be purchasing restraints, as since most states should be covering the vaccine in full. Especially being if you're a federally qualified health center, right? Our mission is to just, deliver that care regardless of your insurance status. And then I know, the American Academy of Pediatrics, their state-based chapters, they're always looking for community quality improvement projects. And again, because we're pediatricians, it's usually around vaccines. So there's oftentimes state-based collaborations for QI. So again, there can be pooled resources on some of those educational materials. The AP also has toolkits about 9 is fine, and how to start at 9. That has, I can try to find that resource and post in here, but I can provide it for later as well. That so you're not having to make patient education materials or provider education materials, and what I mean, I guess I could just keep going on, but I hope there aren't that many there are friends out in the vaccine community amongst the American Academy of Pediatrics. Every boarded specialty has requirements for QI, and so providers need to, if to keep their board certification, need to show that they're doing QI projects. So there can be win-wins like that for maintenance of certification as well.
Awesome. Thank you. And I will shamelessly plug our HPV vaccination rural learning community that was launched last year, which we are doing part two to this year. Tina's in the chat dropping some rural resource roundup information, and she'll drop our learning community, where we do explore some of the QI-based information like PDSA cycles, like you mentioned earlier, TJ. I do want to, though, go ahead and shift over to Shelley, because there is questions about rural, and there were a lot of questions about VFC. So if you want to clarify on some of the, I know you had been dropping some comments in the chat, so I keep pinging over, but if you want to clarify a little bit more for us, the role of VFC when we're thinking about making some of these changes in some of those under-resourced communities or population groups, and how to utilize that.
Sure, happy to. So vaccine financing is very complicated to start with. The good thing about kids is that they, as I said, about 50% of kids qualify for the VFC program. That's a federal entitlement program that covers kids who qualify for Medicaid, who are uninsured, Alaska Native American Indian, or underinsured, which means their private policy doesn't pay for the cost of vaccines. That's a very small number of policies that are grandfathered out of the requirements of the Affordable Care Act. But that amounts to about 50% of kids. The rest of them have private health insurance, and so they are required under the ACA to cover the cost of vaccines. So paying for a vaccine should never be an issue for a child under the age of 19. One of the participants noted that there is an administration fee that can sometimes be a barrier for children who are uninsured, and that's true. The provider is allowed to charge an administration fee for the vaccine to administer a VFC vaccine, but it says very clearly in the federal guidance that they cannot demand that payment, and they cannot refuse to vaccinate a child for an inability to pay that administration fee. So it's just a matter of that individual parent saying that they can't pay for it, and they would still get vaccinated. Um, and then on the private side, at least, under the ACA right now, you've got full coverage of vaccines for any child under the age of 19 as well. So it's ACIP and CDC that really drives which vaccines are covered. And both the private insurance companies and their requirement and the VFC requirement is that it be an ACIP CDC recommended vaccine for it to be covered. And so HPV and all the other recommended childhood vaccines fall within that.
Okay, awesome. Thank you so much, Shelley. In talking about payer mix and coverage, I'm going to shift this question over to David, and we did get this question for you. What is the payer mix for Metro Health Group? What is the rate of getting the adolescent series, including the 2 HPV by age 13? And that's a HEDIS metric. And this person says, I asked about the payer mix because I wonder which percentage of the HPV vaccines need to be purchased by the practices. So the first part of the question, what is the payer mix, if you know? And I can ask the second question because
We're at least 50% Medicaid
okay.
In my clinic.
Okay.
And I think that's probably true throughout the system.
Okay. And do you know the rate of the adolescents getting the HPV by age 13?
I don't know that rate, and it's a hard number for me to figure out what's the
Yeah.
denominator or what's the numerator. If you start from the denominator of all the patients in your system, so that includes some patients who were here at age 13 and some patients who weren't here at age 13. We have historical data on many people, 30-year-olds who have had decades of EHR data. So what's the denominator in that? I don't know how to report on that. So I don't have that figure.
Awesome. Thank you for that, for
Sure.
clarity and just honesty. So we appreciate that. Last two questions. Did your organizations use incentives or any other ways besides the HR prompts to increase HPV vaccination rates? David and then TJ.
So we did not. It's a nudge. I once read a book which talked about being a system architect or a nudge architect. Like I want to build the nudge into the system. I want to put the information there where the providers are looking for it. So the care gaps section, that's like the homepage of the patient, includes a care gaps section, and it's right there on the front page, and it's right there on the preventative care page. That's the biggest effort that we did in terms of outreach. I think we've had speakers come and talk about the importance of HPV vaccine, but they haven't necessarily been coordinated with these EHR efforts.
Okay. Awesome. TJ, same question for you. Any other incentives or other ways that you've really wanting to push those HPV vaccination rates outside of the HR prompts?
Yeah, I put in the chat that we didn't really, we just try to celebrate our shared successes along the way. And then, and more so looked at, so we didn't tie compensation or any other thing. But you could, you can always make rewards, or, sometimes it's public shaming by using comparative rates against competitive providers. But we took the approach of just in seeing that somebody's performance was, if they kept pushing on that alert that they didn't offer the vaccine at the time of the visit, and that was a repetitive theme for them, or that their rates were lower. Again, that was the ability to have this more granular data that I could pull out, so that I could just do a focused training, right? Rather than email blast like, our numbers are dipping, if I could identify that it was just one provider. And again, traditionally it's been, hey, you just came to our organization, you're drinking from the fire hose about what to onboard for our institution. So coming back to them to say, oh, hey, let me walk you through this alert and
Okay.
why this is our culture, to offer vaccine at every visit.
Okay. Awesome. That's good. I know some other places who do like it's almost like a provider report card or progress report card, but yours is more individualized, right? Because you're kind of tracking them where they're making those key decisions and saying like, hey, we noticed that you're not doing X or you're doing Y. So let me like help you, walk you through this process. Last set of questions, and I apologize, I'm keep shifting over. We're getting so many questions and I'm trying to funnel them all. Any provider training? Did you guys do any provider training in your clinic before, during, or even continuously? I know you said that you've had some kind of turnover, but was there any provider training integrated or thought about as part of the big picture implementation of H9 and the EHR system shifts? So I'll start off with TJ.
I think I sort of was just answering that. I think the other piece to say is that, again, vaccination is very key to pediatric workflow. So there's many ways that you could order a vaccine. And so it was just trying to continually try to make these dynamic, they're called smart sets in Epic, but these dynamic order sets to be like the preferred way, right? To make it the most efficient way, so that, again, it just flows into the workflow. And so that it doesn't have to rely on training, right? I feel like in my 15 years of practice, if you build something that requires training, it's just destined to fail. So if you can build something that is going to fit into those 5 R's, then it just becomes, you're making it the simplest solution for the person. You're making the easy thing to do. If you make it easier to do, then and in the right places, then it just, right. That's what helps make it become the new normal.
Okay. Thank you, TJ. David?
I would just echo what I said before and what TJ just said, which is that any Epic tip that we send, an in-basket message or a seminar that we give, is if we're relying on the memory of that, then we're going to fail. My goal in creating decision support is to create it so seamlessly that you don't need to read an Epic tip to know how to use it. It just is part of the workflow. So that was the advantage for me of putting it in the care gap section. It's not a separate alert. It's not a new module that you have to go to. Our pediatric providers are always looking at what's due. Of course, we could do more to say, well, you should be pushing more, you should be addressing it more in different kinds of visits. But fundamentally, to use the functionality, you just have to know how to use Epic, because it's the same functionality.
Yeah. Well, awesome. I want to thank you guys for just taking the time to serve as our panelists for this session and answering some of our questions. We probably didn't get to all the questions, but luckily for those who are joining us via this webinar, you have the email contact information for all of our panelists. Sorry, panelists. So if you have any additional questions, please feel free to reach out to them individually, and I am sure that they will answer the question as best as they can, given obviously the information that they have available, such as David and the denominator rate factor, right? So let's go ahead and transition on and just wrap up for today. So thank you to our attendees. We had so many questions. We weren't able to answer them all. Please follow up with the panelists. We hope that you learned a lot of great information. And with that being said, to make sure that we are putting on successful events like this in the future, we're going to drop a link in the chat or ask that you scan the QR code and complete our brief evaluation survey. We hope that we are putting on webinars that are timely, that are appropriate, and that are just in real time of where we are in the state of HPV vaccination, and that can meet you where your needs are. So please, 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 we know it takes some time, but please go ahead, complete the survey on our behalf, and give us the information that we need to plan any future events on behalf of ACS and the Roundtable to better serve you in your roles at your respective organizations. So with that being said, we hope that you guys learned a great wealth of information today. We want to thank you, not just for attending, but just being a phenomenal partner to this work. We hope that the information was insightful and valuable and applicable. And we want to say thank you so much and have a great remainder of your day.